afternoon and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with commercial interests. If you have a question for our presenter, please hold until the Q&A segment at the end of the talk. If you're attending virtually and have a question, please enter it into the Q&A section. Also, a link to the event survey will be shared at the end of the program, and if you're attending virtually, we'll share that link in the chat section for you. It is now my pleasure to introduce our guest speaker, Dr. Ali Javed. Dr. Javed is a third-year internal medicine resident at Northeast Georgia Medical Center and a graduate of Dow Medical College in Pakistan. His career interests lie in hospital medicine with a focus on providing high-value, evidence-based care to hospital patients. His academic interests include a guideline-driven management strategy and outcomes research in inpatient medicine. Today, he will be presenting practical, evidence-based approaches to the inpatient management of acute gastrointestinal bleeding from the perspective of an internist. Please join me in welcoming Dr. Javed.
Hello, everyone. I'm Ali. I'm one of the third-year residents. Today, for my grand rounds, I'll be presenting contemporary management of acute GI bleeding, practical updates for modern internists. I have no financial or conflict of interest disclosures. So the reason why I chose this topic is because hospitalizations for acute GI bleed is very common, and more than 500,000 hospitalizations in the US are due to acute GI bleed. And of those GI bleeds, upper GI bleed, it accounts for about like 60 to 70%, and lower GI bleed, it's less common, and it accounts for 30 to 33%. And then if we talk about what's the definition of it, so there's no like guideline-driven definition, but we can pretty much say that if you have like an overt bleeding, so the main thing in acute GI bleed is the bleed is overt. By overt, you means it's not subtle or occult. It's something that is visible to a naked eye. And typically it presents as either hematemesis, melena, or hematochezia. And often it's associated with anemia and hemodynamic instability. So that's how you can generally define acute GI bleed. So this is something that we learned in medical school, that there is something called ligament of Treves. It's basically a suspensory ligament, and the embryonic origin, the significance of that basically is that it divides the foregut from the midgut. So we still use kind of this anatomical landmark to basically differentiate between upper and lower GI bleed. So anything that is distal to ligament of Treves is lower, and anything proximal to that is upper. But we only get to know what the source of bleeding is when patients underwent like endoscopies, colonoscopies. So you can never really say for sure. So based on symptoms, you can actually say, even when they didn't have a scope yet. So let's say if someone is having hematemesis, if they are vomiting blood, which is fresh, bright red blood, in those cases, GI bleed is 100% upper GI bleed. There is no chance that it can be lower. If it's coffee ground emesis, which basically means that the bleeding that you are having is getting digested in your stomach, so it's taking a little while for it to basically get vomited out. But even in those cases, 100% of the bleeds are upper. Then we have melena. So melena is interesting because 90 to 95% of the cases, it is upper GI bleed, but there is about 5 to 10% cases where you can see melena in lower GI bleed as well. So what melena basically is that you are slowly bleeding from your upper GI tract, and the blood, it's getting digested, it's getting processed in your GI tract, so it changes color to basically dark or black. Why it can happen in 5 to 10% of lower GI bleed is because, let's say, if you are bleeding in your colon and your colon has slow transit rate, in that case, before that blood comes out of your rectum, it can change color as well in those cases. But that's comparatively rare, so 5 to 10%. But if someone comes to the ED and they're saying that they're having bright red or maroon colored stools per rectum, that is known as hematochezia. And 80 to 90% of the time that's from the lower GI bleed. However, there is 10 to 20% of the chance where it can be upper GI bleed, especially when upper GI bleed is massive. So what's happening there is that you are bleeding so quickly from your upper GI tract that you are basically passing all that fresh looking blood at a rapid rate. So if hematochezia is due to upper GI bleed, those patients would definitely be hemodynamically unstable. They would be hypotensive because they're losing blood so fast. And we can also classify GI bleed based on etiology. So we have variceal bleeds and non-variceal bleeds. We'll talk about it later in detail. So we'll jump right into the management now. So the early management of GI bleed is very important because literature has suggested that early and aggressive resuscitation, it's one of the most important things, and improves to 30-day mortality and also the rebleeding outcomes. So like any medical emergency for GI bleed as well, first you assess his patient's airway, breathing, circulation, and if they are having like massive hematemesis, then obviously they need intubation, especially if they are unable to protect their airways. So I have divided the rest of the management. I have numbered all of those, so we'll discuss each one of them one by one. So the first point I would be talking about would be the IV access. It's very important in these patients. Then we'll talk about fluids and blood transfusion. Next, we talk about coagulopathy reversal, guidelines about PPI therapy, about vasoactive therapy. How about the antibiotic therapy? We'll discuss that too. And then we'll discuss the imaging, scopes, and then key labs that you get in these cases and how do you interpret those. So before we jump into those individual topics, I just wanted to assess like our core knowledge base. So here's a question. So we have a 72-year-old male. He presents to ED for 12-hour history of bright red bloody stools, so hematochezia. He has history of AFib and he's on Eliquis. He reports no prior history of similar episodes. He endorses eating at steakhouse 24 hours ago. He denies abdominal pain, diarrhea, or constipation. Review of system is negative. He's afebrile. His blood pressure is pretty low, so he's hemodynamically unstable, 84/58, heart rate 76, respiratory 16. Basically, rest of the vitals are normal. So we get stat labs for him. His hemoglobin is 6.7, white count is 7.8. Basically, rest of the labs are also normal. We have an INR of 1.6, which is elevated, and then hemoglobin is 6.7. So patient receives 1 liter of LR in the ED, and a type and cross and 1 unit of packed red blood cells are ordered. But what will be your best next step now that all those things are done? So would you administer andexanet alpha, which basically means that would you reverse their coagulopathy? Would you keep them NPO and consult GI for potential endoscopy, colonoscopy? Would you obtain a nuclear medicine GI bleed scan? Would you obtain a CTA abdomen and pelvis? Or would you start them on Protonix infusion and call GI?
Would you like the audience to answer?
Yes.
Okay. I'm going to phone a friend. We're going to go with A.
Okay, so we have option A here. Anyone else who would like to answer? Any other thoughts?
We're all going with A.
Okay, all going for A. Well, the answer for actually is obtain CTA abdomen and pelvis. And we'll talk about it later once we go into the other sections. Okay, question 2. 77-year-old woman presents with melena and dizziness for 1 day. She has history of antiphospholipid syndrome and is on warfarin chronically. Her INR goal is 2 to 3. She also has history of hypertension, osteoarthritis. She is ill appearing and clammy. She's afebrile. Her blood pressure again is low, hemodynamically unstable, 88/52. She's tachycardic. Her physical exam shows that she has conjunctival pallor, she has mild abdominal tenderness with active melena, and her lab testing reveals a very low hemoglobin of 5.9, BUN of 42, INR of 3.8. So her INR is definitely supratherapeutic, and liver function tests are normal. So, which of the following is most appropriate next step in the management of her anticoagulation, or we can say anticoagulation reversal? So, option A is that you would give PCC and IV vitamin K. Option B is you'll hold the warfarin and you will recheck the INR in 6 hours. Option C is administer fresh frozen plasma and IV vitamin K. D is vitamin K alone, and E is andexanet alpha.
Okay.
Any answers for this question?
Yes. What do we think?
I'm thinking B, hold the warfarin.
Hold the warfarin, recheck INR in 6 hours. Okay. Any other thoughts?
We have a C back here.
C, okay, administer fresh frozen plasma and IV vitamin K. Okay, well, the correct answer for this is actually A, that you give PCC and IV vitamin K. And again, I'll talk about it in detail as we move to the next slide. So now, before we jump into those number things about inpatient management, early management, we can talk about like the triage. So this is something that we don't do in internal medicine. This is done by emergency department, so their job is basically to see if they want to ask the hospital medicine to admit the patient, or do they think if they are safe for discharge home. So I don't know if it's actually used, but there's actually a scoring system for that. It's called Blatchford scoring system, and you can see all these like values and the points that are associated with it. So if someone have a score of 0 to 1, they are considered very low risk and they are safe for outpatient management. But anything above that basically means that you have to admit this patient. And you can see from this scoring system that pretty much all the patients that are coming to our ER, they're gonna have it more than 2 or greater than 2. So obviously that's the reason why GI bleed is so common, commonly admitted patients, because most of those would have a score of greater than 2. So they would require admission. Next is for lower GI bleed. For lower GI bleed, we have this scoring system. It's called Oakland. For this, you have a good margin, because if your score is 8 or less than 8, then you can send them home for outpatient evaluation. That's why comparatively hospitalizations for lower GI bleed is less as compared to upper, because lots of those patients who are coming to the ER with this complaint, their score can be less than 8. So they are safe for outpatient. 8 to 14 or anything above that, you would admit them. So now we can jump into like management one by one, like discussing all those steps. So first step is always IV access in these patients. So you need 2 large bore peripheral IV lines. And the reason why you prefer peripheral IV line is because their diameter is greater, and it's simple physics that the larger your radius or diameter is, the higher of the flow you can give through that line. You can use central venous catheter only if they have like massive bleed, which is basically requiring more transfusions or probably even pressor support. For that, you can place central line. And let's say if someone is actually in hemorrhagic shock and their peripheral veins are very poorly visible, in that case, you can also put in a central line. If you are putting a central line specifically for blood transfusion purposes, then it's recommended that you use a single lumen large bore, which is also known as Cordis, Obviously, the reason being the same, that you can transfuse at a higher flow rates. Next, we have resuscitation. So like in septic shock, we have like these guidelines of 30 cc per kg per hour. There's nothing like that in GI bleed or hemorrhagic shock. So there's no definite fluid resuscitation guidelines. However, I have noticed sometimes there's a confusion that, patient comes with GI bleed and you're thinking if you should give them crystalloids or not. Because in our back of our mind, we're thinking if we give them crystalloids, we're gonna cause even dilutional like anemia. But the answer to that question is that while you are waiting for the blood transfusion, always give them crystalloids, because your goal at that point is to maintain adequate perfusion, because they are losing volume, so you have to give them volume. And as soon as your blood is available, then obviously you will start the blood transfusion ASAP. So the general guidelines for transfusion, the core principle behind blood transfusion is basically you try to follow a restrictive resuscitation as compared to liberal, and this has been proven in the studies, because the thing is that if you transfuse them more like liberally, like let's say your trigger is 8 to 10 and your target is 9 to 11, so that's a liberal strategy. In those cases, what can happen is you can, especially if they have portal hypertension, you can worsen their portal hypertension and they can bleed even worse, even more profusely. And also in like non-variceal bleeds, liberal strategy has not shown any lower mortality or rebleeding rates. So that's why the guideline says that for most patients, your hemoglobin trigger should be less than 7 and your target should be 7 to 9. So if someone have non-variceal upper GI bleed, then you transfuse for less than 7, target is 7 to 9. You can increase your target to 8 or 8 plus if they have a history of coronary artery disease, if they are in acute coronary syndrome, like lots of these patients, they come in with NSTEMI as well. So you can say that they have acute coronary syndrome, okay, so you can increase your target to 8. Or if someone is like ongoing shock, they're admitted to ICU, then you can also liberalize your target to 8. Next is variceal bleed cirrhosis. So like I said before, for cirrhotic patients, the target is even more restrictive, because you don't want to worsen their portal hypertension. So the target should be 7 to 8. You should avoid greater than 8 initially. And lower GI bleed is pretty much the same as upper GI bleed. And obviously, if someone is like in refractory bleeding or like hemorrhagic shock, then you have to activate massive transfusion protocol, for which they'll go to the ICU and take things from there. Okay, so this was like one of the questions that we had just 5 minutes ago. So here we're basically talking about coagulopathy reversal. So let's say we have like these different antiplatelets or anticoagulants. So let's start with warfarin, which our patient was on in the question. So if someone is on warfarin and if they're having a life-threatening GI bleed, especially if their INR is like greater than 2.5, in those cases, you will reverse it. You will not just sit back and monitor their INR, you will actually reverse it, especially if it's greater than 2.5. So previously, fresh frozen plasma was used for warfarin reversal, but more recently, 4-factor PCC and IV vitamin K has actually shown to be a better regimen. But you can use FFP if your PCC is unavailable. Next, we have DOACs. Let's say you are on Eliquis or Xarelto, there's like life-threatening GI bleed, then you can reverse it as well if it's life-threatening and it's massive GI bleed. So we have these reversal agents, dabigatran, for that we have eduricizumab, and then adnexate alpha for Eliquis and Xarelto, and so on and so forth. Next thing is antiplatelets, and they are having a GI bleed. So ACG guidelines say that you do not have to routinely transfuse patients who are on antiplatelets and who comes with GI bleed. You do not have to routinely transfuse platelets for them. And then lastly, if someone has liver disease and they are coagulopathic because of that, and they are having GI bleed, in those cases, like generally you can correct like some of the underlying factors and things like that, correct acidosis and all. But let's say if they are like massively or profusely bleeding, especially if they are in the ICU, then you can actually obtain a tag for them, and based on the tag results, you can give them certain coagulation factors and platelets and all, which is a more better strategy for these kind of patients. A few points in general. Let's say if someone comes with INR of 1.5 or 1.4, which is elevated, but in general, these patients are safe to proceed with endoscopy as long as their INR is less than 1.5. If it's greater than 1.5, and especially if it's greater than 2.5, and if advanced intervention is planned, then you should reverse it. And basically, the decision of reversal, it's always a risk versus benefit decision, because you have to balance between the bleeding risk and the thrombosis risk. So it's always a risk versus benefit. Going back to the platelet count, so the only time when you actually transfuse platelets for patients with GI bleed if their count is like less than 50,000, or you can also transfuse for less than 100,000 if they also have concomitant neurological bleed like hemorrhage of some sort. Next, we can talk about PPIs. So for PPIs, I think they are generally I have seen that every patient who comes with GI bleed who have a diagnosis of that, they get started on PPI, but the reasoning behind starting versus not starting PPI is more nuanced. So let's say if someone comes with hematemesis, melena, suspected upper GI bleed, in those cases, definitely, you will start them on PPI until they get the scope. And generally, you would see that emergency department, they give them like a 80 milligram bolus, and then you can start them on a drip, or you can give them like 40 BID until they await endoscopy. Then you have hematochezia plus shock. Like I said before as well, that sometimes hematochezia can be upper GI bleed, especially if it's like very brisk. So hematochezia patients, especially if they have shock, then it's reasonable to start PPI, because then you are thinking it's probably upper source. Let's say if someone has isolated hematochezia, they're just saying they're having bright red blood per rectum, but hemodynamically they are stable, then in those cases, there is no benefit for starting the PPI, because at that point you know that there's a 80% or 90% chance that my patient has lower GI bleed, so why would I start Protonix for them, for example? And let's say if someone have known variceal bleed history, they have history of cirrhosis, they are a readmission for GI bleed. In those cases, you only do PPI if there is a known ulcer component. So you review their past endoscopies and you see, okay, so they have varices, but they also have ulcers. So in those cases, you would start them on PPI. But if it's only varices, then there is no point of starting PPI. So things to keep in mind pre-endoscopy when you are starting patients on PPI. Actually, the studies have shown that they do not really reduce mortality or surgery rates. However, they can downgrade endoscopic stigmata, which basically means that when the GI doctor is going to do endoscopy, the ulcer stage that they're going to see can change based on if they have received PPI therapy or not. So in that way, it may be somewhat helpful to kind of downgrade, let's say, the ulcer stage, but otherwise studies have not shown any mortality benefits. So typically what you do, like I discussed, you give 80 milligrams IV in the ED, and then you can start on 40 BID IV generally while they are awaiting the scope. Now, lots of patients, instead of that, they get started on the Protonix infusion. But actually, the studies have shown that the intermittent high dose, which is the IV injections, they are non-inferior to continuous infusion. So basically, there is no difference. So you can do either one, it's fine. Okay, next we talk about vasoactive therapy, and here we would also talk about, because obviously vasoactive therapy you would do in patients with varices. So how would you know if someone has variceal bleed versus non-variceal bleed before they have a scope? So you can actually tell them based on their story or their history. So variceal bleeds, they are actually usually more severe. They are sudden and massive as compared to, let's say, erosive gastritis or peptic ulcer disease. Those bleeds are gradual and moderate. Hematemesis in variceal bleed, it would be profuse, bright red, because your varices, they are like pumping blood because of the portal hypertension, so it's gonna be profuse. But in non-variceal bleed, because it's like a slow bleed, the blood will get digested some, this and that, so it will be like more coffee ground appearance. Melena is common in both, especially more common in variceal bleed, being the same reason that the bleed is more massive in variceal bleeds. Hematochezia can, like I was saying, if it's a brisk upper source, then upper GI bleed can also cause hematochezia, so you can see it in variceal, but in non-variceal, it's rare. Then again, common sense things, obviously variceal bleed patients are gonna be in shock, hypotensive, other ones are usually stable. They're gonna have history of cirrhosis, alcohol use, hepatitis. The other ones, they're gonna have NSAIDs, history, dyspepsia, ulcer history. Obviously, with liver disease, you will also see findings like jaundice, ascites, and all that on exam. So that's how you can differentiate. So now let's say you have findings which suggest variceal bleed. So how do you go about the vasoactive therapy? So what we have here is called octreotide. So you give octreotide, again you start with a push, 50 micrograms, and then you follow it by infusion. If you don't have infusion available, then you can do 100 micrograms sub-Q every 8 hours. In other countries, we have telepressin, which is actually shown to be superior to octreotide. But octreotide remains a safer, easier option in the United States. The risk with telepressin is that it is more of a vasoconstrictor, especially systemic, as compared to octreotide. So it can increase the risk of ischemia. Basically, how vasoactive therapy works is basically they cause splanchnic vasoconstriction, which reduces your portal pressure, and that's how they help in these situations. So next we have antibiotics. So all cirrhotic patients, everyone with cirrhosis, they have known history, they come to hospital, they have GI bleed, you must start them on antibiotics. It's simple as that. So you just start them on Rocephin for 7 days. We'll talk about the duration further in the upcoming slides, but you start them on Rocephin. If they have beta-lactam allergy, then you have fluoroquinolones. Yeah. So now we talk, this is going to be the busiest slide because here we're going to talk about how do you progress with the imaging and scopes. Now, this is obviously a decision that is generally taken by gastroenterologists, but there are some things that you can actually order as well if you think your patients need them before they get a scope. So let's talk about endoscopy. Endoscopy is, obviously you'll do it when you're suspecting upper GI bleed, but what does the guidelines say about when they should get it, you know? So if you suspect a non-variceal bleed, then the consensus is that early endoscopy less than 24 hours is a good strategy. But rushing it, like doing it less than 6 hours, has actually shown no benefits as compared to if you do it between 6 to 24 hours. But if you delay it more than 24 hours, then it is associated with increased length of stays, rebleeding, and transfusions. So that's for non-variceal bleed. For the variceal bleed, generally you should aim for more of an urgent endoscopy as compared to non-variceal because, like I said, these patients would be more so in the shock or bleeding more profusely. So less than 24 or around 24 hours is recommended. The studies have shown that if you do it less than 12 hours, then there is no mortality benefits. So 12 hours to 24 hours is a good mark for these patients. And studies have actually shown that if you do it like urgent, like less than 6 hours, then it's possibly associated with worse outcomes. And the reason for that is that those 6 hours time period, they should be utilized for resuscitation and stabilization of the patient. In those 6 hours, if you send them for endoscopy, that can have worse outcomes because probably you haven't actually stabilized them all like in a good manner until that time. So that's for endoscopy. Colonoscopy, obviously you'll do it when you have presenting symptom is hematochezia and they are hemodynamic stable. So at that point you are thinking, okay, the likely source is lower GI bleed because they are hemodynamically stable and they have hematochezia. So then you can proceed with colonoscopy instead of endoscopy. Especially if they have a history of known colonic source, they have history of AVMs, hemorrhoid, diverticulosis, then you'll proceed with colonoscopy. If you do it within 24 hours, you can identify a bleeding source in 70 to 85% of the cases, and it has associated with shorter hospital stays and reduced rebleeding events. So this is actually something that I was re-investigating yesterday, and the most recent guidelines in 2023 from ACG, they actually say that even if you delay colonoscopy after 24 hours, there is not really much worse outcomes associated with it. So this statement, I think, is more true for the ACG guidelines in 2021, but in 2023, they have basically said that you can delay for 24 hours, it's fine. So let's say if endoscopy, we often see that endoscopy is negative and then the gastroenterologist, they schedule the patient for a colonoscopy after that. So the reason they do that is if endoscopy is negative, but they continue to have persistent hematochezia or melena, then colonoscopy can be performed while they are in the hospital. Let's say if endoscopy was negative, but they continue to have like iron deficiency, anemia, but overall they are stable. In those cases, you can do colonoscopy as an outpatient. Okay, so this was the first question that we did, which was about the CTA, which is also in our EPIC system. It's known as CT GI bleed as well. So basically, it's CTA of abdomen and pelvis. So what you do, when do you do it? So like this is something that you can order like in inpatient medicine, right? So you have to know when to do it versus when to wait for the scope. So for upper GI bleed, CTA is recommended for ongoing or recurrent bleeding when endoscopy has failed. CTA is also recommended if endoscopy cannot be performed, such as due to massive hemorrhage, helps in planning for IR embolization or surgery. So we are talking about two things here. Sorry. One thing is that if your EGD has failed, for any anatomical reason or any reason whatsoever, and your patient is still bleeding, then you'll get a CTA. Or let's say if they have like a massive hemorrhage, and obviously if they're hemorrhaging acutely, you cannot do endoscopy. In those cases, you will also do a CTA so that IR can do embolization or the surgery if needed. For lower GI bleed, so this was the question actually. For lower GI bleed, if you have a patient who's coming with hematochezia and they are hemodynamically unstable, then the first line test you should do for them is CTA. So that was the answer to that question. So you do CTA or CT GI bleed in the patients who are coming with hematochezia with hemodynamic instability. Let's say if you had a negative EGD, you had a negative colonoscopy, so now you are thinking about obscured bleeding. Even in those cases, you can do a CTA. It can detect a bleeding rate of 0.3 to 0.5 ml per minute. Next, we have this tagged RBC scan, which is also known as a nuclear medicine study. So again, basically, it can be considered when the site of bleeding is uncertain and both upper and lower endoscopy plus minus CTA are non-diagnostic or not feasible. So let's say your patient comes in, he has melena, he undergoes upper endoscopy, it's negative. He undergoes lower endoscopy, colonoscopy, it's also negative. You cannot do CTA. For example, patient has AKI. In those cases, you can do a tagged RBC scan. Or even if you do a CTA and CTA is negative, then also you can consider tagged RBC scan, because at that point you don't have a clue what's going on. So, but the main thing in tagged RBC scans is that it's done in hemodynamically stable patients. The reason for that is that this imaging procedure, it lasts about 1 to 2 hours, and it detects like very slow bleed rates, like 0.1 ml per minute. So it's really good at detecting the bleeding, but your patient have to be hemodynamically stable enough to tolerate this long procedure. And it's useful when you want to look for the bleedings which are intermittent and slow. The limitation of this study is that it provides temporal localization, but the anatomic precision is poor. So what that basically means is, if any one of you have actually ordered it, the way radiologist will read it, he will basically say that there is like a source of bleeding in mid-epigastrium or right lower quadrant. But beyond that, they wouldn't specify like which exact vessel is bleeding or which exactly part of their GI tract they're bleeding from. So the anatomic precision is pretty poor with these studies. So let's say if you have a patient who had all these testings and you're still unable to find a source of bleeding. So in those cases, you can call them that they probably have like obscured bleeding. It's generally thought to be of small bowel origin, where your scopes can generally don't reach. So what guidelines recommend is that you do a capsule endoscopy, and after that, the gastroenterologist, they can do device-assisted enteroscopy, and capsule endoscopy has a diagnostic yield of 50 to 70%. It's pretty rare to go to this point where you are actually diagnosing patients at obscure bleeding. It's only like 5 to 10%, but it happens. I have seen it. So you have key labs and interpretations. Obviously, we get labs on all patients. Hemoglobin, obviously, you know what we're doing with that. You do type and cross match. BMP, CMP. One important or interesting thing is that if someone has, if you are a little bit undecided, you know, if it's upper versus lower GI bleed, if your BUN creatinine ratio is elevated, then it's more likely to be upper GI source. So BUN would be elevated in upper GI source. Coagulation profile, like we discussed, it can guide us to reverse coagulopathy and to see if the patients are actually safe for endoscopy or not. Let's say their INR is greater than 2.5, then you'll probably want to reverse it first. A liver function test, especially if someone has cirrhosis, then you can look at all those numbers. Lactic acid is good for assessing for perfusion, and ABGs. So now we have inpatient post-endoscopy management. So let's say your patient already had an endoscopy now, and now they are still in the hospital. So then what are the management goals here? So I have divided it also into sections. I guess we'll just start discussing them. But the first one is guidelines on holding and resuming antiplatelet and anticoagulant medications, duration of PPI therapy, duration of vasoactive therapy, role of beta blockers, very important, duration of antibiotics, serial hemoglobin monitoring, diet, role of NG tube or suctioning. So before we jump into the remaining section, we have another question. So we have a 68-year-old man with a history of CAD, presents with melanine fatigue. He's 8 weeks post-drug-eluting stent placement. So he just had a PCI 8 weeks ago for an anterior STEMI, and he's been taking aspirin and Brilinta. So on arrival, his blood pressure is 102 over 64, hemoglobin is 7.4, down from 13 2 months ago. He undergoes endoscopy, which relieves a bleeding duodenal ulcer. Endoscopic hemostasis is achieved. He started on high-dose IV PPI. Which of the following is most appropriate option regarding antiplatelet management in this patient? So first option is that you will hold aspirin, and after that you will continue Brilinta monotherapy indefinitely. You will hold Brilinta on admission, but continue aspirin monotherapy indefinitely. Then you have continue Brilinta on admission, restart aspirin 3 to 5 days after once they are stable. continue aspirin and restart Brilinta after 3 to 5 days once stable. And the last one is hold both agents for 14 days and then restart the DAP once hemoglobin normalizes. So do we have any thoughts on this question?
What do you think, guys? Anybody want to give this one a shot? Somebody says C.
Yes, that's actually the correct answer. So if the, we'll talk about it later, but yeah, C is the correct answer. So we're running out of time, so I'll try to be quick now. So we have 64 men presents with hematemesis and dizziness for 2 days. He takes naproxen, hemoglobin 8.1, hemodynamically stable, undergoes upper endoscopy, which reveals a gastric ulcer with a non-bleeding visible vessel forest 2A lesions. Endoscopic hemostasis is achieved, started on IV PPI. Which of the following is most appropriate PPI regimen after endoscopic therapy? So the main thing in this question is that you have a peptic ulcer disease, which is a forest 2A lesion, and patient is on IV protonics. The question is how long you're going to continue it for. So we have all these options. Does anyone have any answers or any ideas?
What do we think? A, B, C, D, or E?
Okay, so the answer to this question is option B. You do IV PPI for 72 hours after they have achieved hemostasis, and then you continue oral twice daily for 14 days. And again, we'll get into it later. Last question. So 65-year-old male presents to ED for altered mentation and dark stools. He has history of alcoholic cirrhosis, not on anticoagulation or antiplatelet agents. On exam, he's ill appearing and disoriented. Temperature is low-grade fever, blood pressure 95 or 72, heart rate 102, hemoglobin is 7. You have all these labs number, which basically is significant for ammonia of 75, T-bili of 3.6, INR of 2.1, and lactate of 2.8 with the albumin of 2.7. So you can say that obviously this patient has cirrhosis. So patient is started on ceftriaxone, pantoprazole, and octreotide. Endoscopy is performed, which reveals variceal bleed, but there is no peptic ulcer disease. So what would be the best step in the management of this patient? We have these 4 options. The key point here is that there is variceal bleed, but there is no peptic ulcer disease. So what would be the answer?
Oh, we're getting some mixed answers out here.
Oh, okay, so the
Some
correct
people
answer
say
is D.
A or D.
So obviously you'll stop protonics, you'll continue octreotide for 5 days, and you'll continue rifampin for 7. We'll get into that later. So just quickly want to go through all these slides now. So if someone is on aspirin for secondary prevention, which basically means they never had a stroke, never had a TIA, never had a coronary artery disease, and they comes in with GI bleed, then you basically, I'm talking about primary prevention. So there doesn't have any history of any of these conditions. Then you hold aspirin in acute GI bleed, and you actually never restart it because they have no pathology to begin with, right? But if someone comes in with on aspirin and they are on it for secondary prevention, which means that they are on it for, let's say, CAD, stroke, who knows. So in those cases, you should only hold aspirin for only life-threatening bleeding. I see it getting held for like pretty much everything, but you only hold it for life-threatening bleeding. Otherwise, aspirin for secondary prevention is okay to continue. Then next thing is if someone is on DAPT. So we had this question, and you all answered it correctly, that if someone have a recent PCI, 30 to 90 days, then the guideline says to continue P2Y12 inhibitor and hold aspirin and restart aspirin in 3 to 5 days. However, if someone is beyond that 90 days mark, then the guidelines actually reverse. In that case, you basically continue the aspirin and hold P2Y12 inhibitor. The reason for that is that within those 30 to 90 days, the risk of stent thrombosis is very high, so you want to keep the coverage for a P2Y12 inhibitor. But having said that, this is something that you can also consult with like multidisciplinary service, with your GI team, with your cardiology team for their input on these things usually. So warfarin, same thing as DAPT, you hold it for acute GI bleed, you start them 3 to 5 days. DOAC, same thing, you hold it and then you start it 3 to 5 days, and 3 to 5 days after they have hemostasis, so after the endoscopic or colonoscopic procedure is done. So this is about the other question we discussed about the duration of PPI therapy. So for Forest class 1A to 2B, these are the ulcer stigmatas that you can see in endoscopy. I have actually written here what each of these classes means, but because of time restraints, I won't go into that. But main thing is that 1A to 2B are the severe ones, and 2C and 3 are not severe. So for 1A to 2B, you basically do protonics for 72 hours, IV protonics for 72 hours after their hemostasis is achieved, and then you do oral PPI BID for 14 days, and after that they should be on oral PPI once daily after the 14 days. For class 2C and 3, because these patients are pretty stable, if you look at their ulcers, they don't look pretty bad. So for these patients, you can do just the once daily oral PPI. So if you're reading the endoscopic note and the gastroenterologist has written that the ulcer class is 2C or 3, then you can actually stop the IV protonics and switch them on oral. Many of the times they just say that it's like erosive gastritis. In those cases, you can just stop the high dose therapy and do PPI as clinically indicated. Yeah, so if someone has varices without coexisting PUD, then you can just stop. Vasoactive, so you continue it for 3 to 5 days. We're talking about octreotide here, so you continue it for 3 to 5 days after the varices are confirmed and after the hemostatic control is achieved. After they have ligation, then you continue it for 3 to 5 days. Prolonged use greater than 5 has no added mortality benefit. It actually has these side effects. So beta blocker, all the patients with cirrhosis, when they come with variceal bleed, before you discharge them, you should send them on a beta blocker. The reason for that is that these statistics are very important, that the non-selective beta blockers, they reduce variceal bleed by 45%, the first variceal bleed, and rebleeding by 40% compared with no therapy. So anytime these patients with cirrhosis, they have endoscopy and varices are found, then you should start them on beta blocker. But the timing of it depends because they have to be hemodynamically stable. There have to be no active bleed or sepsis, and you should only start it when the octreotide is discontinued. And the options we have here for non-selective beta blockers is carvedilol and nadolol. Next, we have the antibiotic duration. This is also very important statistics because prophylactic antibiotics, they reduce the bleeding rate by 30 to 40% and mortality by 20 to 25% in patients who have variceal bleeds and they have history of cirrhosis. So you do rifampin for 7 days, that's the preferred regimen. If endoscopy reveals a non-variceal source and patient does not have cirrhosis, antibiotics can be stopped immediately. So let's say you are thinking there's variceal bleed, but when they do endoscopy, it's actually not, and there is no history of cirrhosis, then you stop it. But if they have history of cirrhosis, and even if the endoscopy does not reveal varices, then some clinicians, they still do it for 3 to 5 days to reduce the risk of SBP and all. This is obvious, so I'll just skip it. This is also, like, I don't think so, it's that important. Yeah. On this slide, there is an interesting point. So we have like NG suctioning, which was done in the past for GI bleed patients, and it used to basically help them know if it's an upper versus lower GI bleed by looking at the aspirate. But recent recommendations, they suggest that there is no benefit in doing it. unless if someone is admitted in ICU and they have like massive hematemesis and you need to do gastric decompression, that's the only indication where you will do it. But there's something that I found interesting actually when I was looking at this topic is that I don't know if it's done. I think it's not done, but actually meta-analysis have shown that if you give IV erythromycin 30 to 90 minutes pre-endoscopy, it can accelerate the gastric emptying, and it has all these benefits. It decreases the procedure time, it decreases the hospital length of stay, and it can be most beneficial in hematemesis or high clot burden. So this is something new and interesting to me, and I'll probably look more into it. So busy slide, but basically most common cause of upper GI bleed is peptic ulcer disease. Most common cause of acute lower GI bleed is diverticulosis. Then I have written all these in-hospital mortality rates for all these bleeds and everything. Yeah. So in general, the main thing in this slide is that in general, in the last 2 to 3 decades, the outcomes for acute GI bleed have improved quite a lot due to early endoscopy and everything. However, there are still high rates for rebleeding, like you can say 15%, and readmissions 5 to 7%. So these are still like persistent challenges, and we can actually make a difference in these things by making sure we are doing good discharge optimization, secondary prevention, and they are following up with the gastroenterology. So a little about future avenues. Obviously, AI is in everything. So now there are some prediction tools with AI. They can, while they are doing endoscopy, the AI can also help detect the ulcer stigmata and whatnot. Other new advances, these hemostatic powders. So let's say if someone comes with like a upper or even a lower GI bleed and their bleeding site is like diffuse, you cannot really identify one particular vessel that you can clip or coagulate, then you can basically throw this powder on them, and this powder will form like a barrier, and it will provide temporary hemostasis until you do the definite procedure. So this is something new which is being done now. Then there are some novel things that being developed as far as endoscopy goes, hybrid IR endoscopy suite, and tagged RBC scans. Like I said, they are not that good for anatomic localization, so they are being replaced by high resolution CTAs. So these are my reference. Thank you. Any questions?
That was a nice talk. I wanted to share that there are two things to be wary of. One is the time frame for endoscopy, that the gastroenterologists use not the time that the GI bleed started, which could be 1, 2, 3, 4 days ago, but the time of presentation. And thus, to my second point, the concept of hemodynamic stability is far more important. There's taking care of patients and thinking outside the guidelines, which is what you're trained to do as a physician. So if somebody is hemodynamically unstable, you must address the coagulopathy first as you are resuscitating the patient, and then do your diagnostics and therapeutics always.
Yes, yes. Thank you.
Thank you.
Thank you, Dr. Javed. That was very informative. Have you seen any comparison of vasopressin? Can that be used with terlipressin in place of terlipressin?
No, I mean, when I was reviewing the ACG guidelines or European guidelines, basically they talk about octreotide or terlipressin. I haven't really seen vasopressin in there. Most of the things that I was talking about in these studies, they come directly from ACG guidelines of 2021 and 2023. So you all can basically have a look at that. It's pretty interesting, and it can help guide us management for. It's very common. Like I'm pretty sure people who have MTS, like they will have someone with GI bleed. So.
Thank you.
But yeah, I didn't see that. No.
When it comes to warfarin reversal, what was the dosing on that, or does it depend on the INR? Because I know that the INR is more difficult to correct the closer it is to normal. Did they have any, did you see any data on that?
So, like I was saying in one of the slides, that INR of 1.5 is generally considered safe for endoscopy. So as far as the dosing goes, for the PCC, for the prothrombin complex concentrate, there's no specific dosing for it. It's basically like a transfusion. Those are just factors, you know. And then IV vitamin K, if you try to order it in Epic, you can see 5 or 10 milligrams. So based on how much you want to correct, how far they are from 1.55, you can choose a dose. But generally, if someone is hemodynamically stable, you're going to do 10, right? And then after that, you know, after some time, you can repeat their INR. If it's down to like 1.5 or around that range, then they should be safe for endoscopy.